Hi, I'm Harriet. I'm, as I said, lead pharmacist for old people at Swansea Bay.
And I'm Sheridan. I'm one of the clinical leads for elderly care. So we've basically going to present to you a PowerPoint on polypharmacy. We're going to try and make it interactive, so please participate.
Yeah,
I apologise to the sound man before.
Sorry.
But yeah, please try and be interactive because it will make it a bit more interesting, hopefully. So it's come off the back of, so basically we have updated the AWTTC Polypharmacy guideline between us, and we've also had massive help of Emma, who's in the audience, and also a lot of specialities. So some people are in the audience that have helped us write this, because we are by no means experts in mental health or pain. So we've had a lot of help to make this really up to date and really useful document. So this is what we're going to basically highlight. The guideline is quite large, so we would be here pretty much all day if we went through everything. So we've just picked out some key bits just to sort of highlight to everybody. Most of the information obviously is in the guideline, and there's a lot more information on these topics in that guideline. And then at the end we've got some, well, depending on time, we have got case studies that we would like to have some input from the audience. So first of all, to think about is what is polypharmacy. I'm aware that a lot of people will already know this, but just to highlight that, we think of it as in two different ways. So one is appropriate. So obviously we've got an ageing population, they've got a lot of comorbidities, and we need treatment for those comorbidities a lot of the time. So if, say, a patient's on multiple drugs for multiple problems, but they're all optimised, they're all evidence-based treatments, there's no duplication, drug interactions, then we class that as appropriate, even though they're on a lot of medication. The problem that we're trying to tackle, with this, especially with this guideline and trying to promote it, is the problematic polypharmacy. So again, you've got your same patient with multiple problems, but they might have several drugs that all do the same thing for the different conditions. They might not actually be appropriate any longer, but nobody's actually reviewed them. There might be a lot of drug interactions because of the amount of polypharmacy. So we would class that then as problematic. And they are the patients we're trying to target and look at. So why is it important? So it's a major global problem. So with over 50% of people taking medications are inappropriately prescribed. And this might be because they haven't been reviewed and they were appropriate at one point. Or the guidelines and evidence have changed and we're not sort of kept up to date with treating them appropriately. And obviously more polypharmacy results in more harm from medicines. So 11% of unplanned hospital admissions, and 70% of these patients being of the older generation. And only 50% of these medicines are estimated to be taken as prescribed. Which again, we can prescribe all the best medicines in the world, but if the person isn't able to take them or doesn't want to take them because we haven't included them in the decisions, then that creates another element of polypharmacy that becomes quite problematic. So we're going to have a little look at frailty as well, because that comes into how we tackle polypharmacy. And we've got a case study at the end to show why we would potentially take a different approach depending on somebody's frailty. So there's lots of different frailty scales out there. The one we tend to see used quite a lot in our health board is the Rookwood Frailty Scale. And there's apps and various things you can have on your phone that you can use if you're sort of in that environment to look at somebody's frailty scale, just to give you a bit of an idea of what stage they're at in terms of when we review drugs, what are we really looking at and what's important to that person at that time. So probably a lot of people would be aware that frailty is a multi-component syndrome with 5 geriatric giants. So we'll get them up so you can see. So that's why we've looked at some of these giants within the guideline as well, to try and highlight the problems associated with them and why we need to review the polypharmacy in line with these as well. So falls, immobility, delirium, incontinence, and obviously the susceptibility to drug adverse events. So just to sort of get everybody on the same sort of page, so it's been estimated to occur in what percentage of people over 65. Does anyone want to hazard a guess of how big our frailty is over 65?
No takers, I don't think.
40%.
Yeah, okay, we'll go with that. So, 10% of people are aged over 65, but then that rapidly increases as we get over the age of 85. And obviously our lifespan is much longer now these days. We have a lot of people over 85 on multiple drugs. So you'd be very, very, I'd say it's very rare, especially from a secondary care perspective, to see somebody with a drug chart with about 4 or 5 drugs on it who are over 85. That would be a really rare occasion and a good day for us.
Yeah.
And then true or false. So multimorbidity, polypharmacy is common in patients living with frailty. So they have an increased likelihood of adverse drug reactions, falls, cognitive impairment and delirium. Would you say this statement is true or false? True, yeah. Because they're all part of our geriatric giants, which we've just talked about. So there's tools out there which you can use if somebody is frail. It's slightly different from what you might have seen the stop-start tool. So this is a different, very similar, but a very different approach to how we would do a medication review in somebody who is frail. So this is included in our polypharmacy guideline, but it's just to highlight to you that there is a separate tool you can use if somebody is particularly frail. And this is the list of meds. Again, it's quite hard to see them, but the difference being things like statins are in there, bisphosphonates, so drugs that work over a longer period of time. If somebody's really frail, are they actually going to get any benefit from them? And it's something we should be thinking about, improving their quality of life and actually giving these medicines to those patients. Is there any benefit from it? And high-risk medications. So we've highlighted these as well. So when we wrote the guideline, this acronym was new to both of us. We were going off sort of the list that probably everybody's seen of the drugs that cause the most admissions, which is a little bit out of date now. And yeah, from speaking to specialists in different areas, we've come across sort of the most up-to-date information. So this was one of the things that we both learnt writing this guideline, is the APINCH acronym. So this highlights the high-risk medications. So when you're doing a medication review, regardless of whether somebody's frail or not, these are sort of the groups of drugs we should be homing in on, just to see if they are still appropriate. Are they being used appropriately? Just to try and help that medication review and try and narrow down, if we've got limited time, what do we need to look at? What's going to have the most benefit?
So another thing that we like to focus on is the 6-day rules, which I think obviously a lot of us have come across this, but just to highlight, these are also in the guidelines and they're obviously really important for us to try and review these medications, and I think also raise awareness, because I think there are some people that maybe aren't that aware that perhaps we should hold these medications. So it's just to let you know that these are in the guidelines as well. So as well as what Sheridan's already spoken about, we've got deprescribing guidelines. So some medications obviously need a little bit more support when it comes to deprescribing. We can't just suddenly stop them. So we've been fortunate to get some help from a lot of different professionals and helping us to write some guides on how to safely deprescribe. So things like antipsychotics, which we know is a really huge problem at the moment, particularly in Wales. The prescribing of antipsychotics in dementia, so trying to safely deprescribe those, antidepressants, corticosteroids. There's a few different things in there. So if anyone has got a patient they want some support in deprescribing these type of items, please have a look at the guidelines, and there's stuff in there for them. And this is just an example of the treatment algorithm. I know, like on the virtual wards and stuff, we get a lot of queries about bisphosphonates and the duration, so that can be quite useful when you're just trying to figure out, you know, should a patient be staying on a bisphosphonate or not. So next we're going to go on to falls. So again, some more questions for you guys. True or false, polypharmacy increases the risk of falls? True, yes. And actually just taking 4 medications of any pharmacological classification, so it doesn't have to be a falls risk medication, can increase your risk of falls. And if you think about, I don't know what types of patients you see, but certainly the types of patients we see, 4 medications is really, really small amount. It would be very rare to see that. So a lot of our patients will be at risk. What percentage then of people aged 65 years and over have a fall? Anyone want to guess? Should I get the answer? I won't test you too long. Oh, sorry, I jumped the gun there. 30% over 65, and then again that jumps up to 50% in patients over 80. And it was estimated to cost the NHS 2.3 billion in 2013. So, you know, not only is it a huge health problem, but it's also a huge cost to the NHS. So if we can try and prevent falls, you know, it's a really big area. So medication obviously can cause falls, and it can increase your risk of falls for a number of reasons. So sedation, hypoglycemia, confusion, impaired postural stability, orthostatic hypertension and dehydration. And in the guidelines we've created a list of medications that are classed as high risk and intermediate risk. So this is a small example. There's a more extensive list, and if you have a look at some of these medications, I'm sure they're quite common in the patients that they're definitely common in the patients we see, and they're classed as high risk. So if you are having someone that's having a fall quite frequently, it's always worth having a quick look at the medications to see is there anything that, even if you can make a switch to something else to try and reduce that risk. And you might have heard of anticholinergic effect on cognition, or you might have also heard of the term ACB. So anticholinergic effect on cognition is a little bit more accurate because it looks at the drug crossing the blood-brain barrier. So it gives us that look at the potency. So why is it important? So there's increased risk of adverse effects such as cognitive decline, dementia, and even mortality. But as well as that, then you've got adverse effects such as constipation, urinary retention, and sedation. So it's important to try and look at these drugs, and again in the guidelines we have a list of medications, and I think this is really useful to use with patients because it's a colour coded thing. So it's like that traffic light. So if you have a patient and you're trying to involve them in the conversation about stopping medication, if you show them, like, you know, this medication is a red, is a high risk one, and you can have that conversation maybe a little bit more easy about perhaps switching to something else or stopping it. Generally, if a patient's on a medication that's classed as 2 or above with this score, then we'd like to try and review it. And obviously, if they've got a total score of higher than that as well, we try and look at that. We aren't sponsored by the guidelines or anything, so there are other alternatives available. So MediCheck is a really useful tool as well. So it's a calculator, so you can just pop in all your medications. It comes up with a score, and it also looks at like dizziness and falls risk and stuff. So that's another useful tool to use if you didn't already know about it. Do you want to talk about the next one? Yeah.
So this kind of goes back to what I mentioned earlier about the 50% of medicines are not taken as intended. So again, with all the great will in the world, all the evidence-based medicine, if somebody's physically not able to take something, the likelihood is they're not going to, or if they really don't want to. So we need to really look at this because it contributes massively to medicine's waste as well. So 200 million each year in wasted medication. So it is a key part of polypharmacy in a way, just to sort of work out how somebody's taking something and is there any help available for us to support them to take it. So we've done within the guideline a section on medicines adherence and the things we should be considering when looking at somebody's medicines a bit more holistically really in terms of their social side as well of how they're going to manage them. So just briefly sort of what support is available. So you know, we've got things like dossier boxes, which there's pros and cons to them. Things like large print labels. Do patients need help in general? So do we need to think about a social care package? Medicines reminder charts. So a lot of our technicians in the health board we work in look at patients and sort of think about where they're just writing their medicines out in a list, what time of day, what are they for. Would the patient benefit from that just because they've got more education about why they're taking something? And as you can imagine, if you were handed a big bag of tablets, I know I would struggle to sort of think, where do I start? So it's a nice little list then to sort of get their head around what time of day and what they're taking and why. Some places do text alerts. Some of the dossier boxes you can get now have an alarm system on them, so they actually rotate the time of day and remind the patient to take them. And things like Haler aids and just bits and bobs to help dexterity in terms of eye drops, inhalers, and devices to help patients pop things out of blisters as well if their dexterity is bad. So there's a lot of things out there, but I think the main thing is just to look at whether what we've got available is appropriate, not sort of just going down the route of, oh, we'll just get them a dossier box and that will solve all our problems. There's a lot more things available. We're quite lucky that we've got a medicines management service that will go in and see patients in their home and assess them in the best environment. I know not all health boards have that availability to them, but we're quite lucky in that extent. So we've got teams that will go and do that bit for us in the community. So my biggest bugbear is MDSs. So there's pros and cons. So we're just trying to have a think. There's lots of them, but does anybody know any good things about having a dossier box? No?
Does anyone want to say any of the risks, perhaps?
Yeah, risks, then we'll go with that.
Yes, Felicity.
I was going to say they don't lend well for dose titrations for, patients that are having heart failure medications, for example, being up and down titrated. They just, if you've had 4 weeks supply of trays, it's game over, back to the scripts again.
Yeah, definitely changing medications, and then you have to get a whole new lot of scripts, and then that's time for the pharmacist. Yeah, it's definitely an issue. Anyone else? Yeah. I'm really sorry about
Number
this.
12. There we are. I could go on for hours about this.
Yeah. We all
come up with us.
No sick day rules. You can't put PRN meds in. You can only use oral dosage forms. Stability of the products.
You've probably got more than we have on our list.
Yeah.
There is a very small benefit, which is for people who have literacy issues and struggle with interpreting something that isn't obviously visual.
Yeah.
Beyond that, visual and literacy issues, I can't really see any benefits of them.
I agree with you. So yeah, this table is in the guideline as well. So it's just to highlight that potentially these sorts of administration aids aren't for everybody. I certainly see a big push for them, in going to meetings and discharge meetings in particular, that these things are going to solve everybody's problems. And they don't always. I've actually seen patients taking knives to them because they can't open them. Taking all of the week's morning meds in a day because that's how they think they should use them. So there is some safety issues with them as well if somebody doesn't know how to use them. Or if their cognition is impaired, that's just a whole different kettle of fish again then in terms of whether they are appropriate to be using something like that. Yeah.
I was going to ask about we've got a pharmacy near us that does, they call it Medipack, where it's like a roll, and they pull it out one after the other.
That's interesting.
I don't understand how that deals with any
I've not seen that actually.
No, I've never seen that.
Lunchtime one, then they're out of sync forever.
Yeah, pretty much.
I've never actually seen that before. That's interesting.
So
Something to be aware of. We'll have to
have to have a look at that. Yeah, so it's just to highlight there are issues, they're not going to solve everybody's problems. So where are we on time? So we're going to have a little look at the case studies now, again, just to try and put our guideline into use, basically, and to try and get you guys thinking about polypharmacy. So do you want to do the first one?
Yeah, so we'll try and give you a couple of minutes and, tell us if we're over time. And I know it's like almost lunchtime, so everyone's probably desperate for us to get off the stage, so we'll try not to be too long. We've got Mrs. Jones, who's an 89-year-old lady, past medical history of falls, type 2 diabetes, diet controlled, hypertension and back pain. These are her bloods, but they're all... Oh, no, I didn't put them on the other side. So she's got a little bit low sodium, her potassium's in range, creatinine's okay, HB is a little bit on the low side. And her platelets are okay. She's got high folate and her weight's 60 kilos, blood pressure 100/70 and her lipids are in range. So this is her medication. She takes nothing over the counter. We're going to give you a couple of minutes and then afterwards maybe if people can shout out if there's anything that they would like to review. Perhaps is there anything, mainly we're looking at de-prescribing. So if you had a patient come into clinic and you had these medications, because I think regardless of the setting you work, you're going to come across, well, maybe if not paediatrics perhaps, but older people, and they're going to be on multiple medications, so it might be useful just to have a look at anything you might want to review. Okay, great. So does anyone want to have a look, does anyone want to shout out at anything, they might want to review? You stopped it all, did you? Full marks.
Yeah.
A bit too excitable then. Yeah, so if we look at the medication there, I think we can stop most, if not all. For example, just basic things like the folic acid, it was greater than 20, last reviewed in 2017. Citalopram 40, last reviewed probably 14 years ago. Does she really need that now? Or has she ever had any review by mental health? Cocodamol, is a high dose. Cause lots of problems there. Simvastatin, does she actually need that now? She's 89.
Yeah.
Housing mobility, is she more bedbound or whatever? So the alendronic acid, that was last review 10 years ago.
Amazing, yeah.
Amitriptyline 10 milligrams for pain. Is that really good enough? Really?
Amitriptyline.
Yeah, and she, as I say, she's on Ramipril 2.5. Her BP is within range from not drinking very much either, so
yeah, her BP was on the lower side, wasn't it?
Yeah.
Should I pull up the so her AEC score was a total of 4, 1 for citalopram, 3 for the amitriptyline. There's increased risk of serotonergic effects for the 2 of them, and like you say, we could basically review all of them, and obviously it's patient specific, so we'd have to speak to the patient. She was started on aspirin for primary prevention. That's no longer indicated, so that's something we'd review. And then because we've reviewed that, we could stop the omeprazole, and again, if you'd want to monitor for rebound effects of that, you might want to give her a bit of pep talk before completely stopping her, and then stop that. Simvastatin, she is 89, so you could consider stopping that one. She was hypertensive, so you could stop the Ramipril. Speak to her about her pain. Is she still in pain anymore? When did she have her back pain? She's on amitriptyline and cocodamol. She's a falls history patient, so perhaps we could review those. Her citalopram is a high dose, so a useful resource. I mean, a lot of you have probably already seen it, but in the BNF, they've got a prescribing for an elderly section, particularly, I haven't looked at the paper BNF in a long time, on the online version. Underneath the drugs, they'll tell you a bit more information, so that's a stop drug, and so that's one we can definitely reduce a very minimum. And like you said, the folic acid, she's usually we prescribe it for 4 months. She's been on it for years, and her folate is fine. Alendronic acid, we've got the guideline in the table that we showed earlier. That's something we could review. Calci-2, we could maybe keep her on the Calci-2, or she likes it. Yeah. So Sheridan's going to go on and do another case study for you guys next.
So this is a slightly different sort of way of looking at a medication review. We're going to think about somebody's frailty in this one. So we've got 2 patients, Mrs. A and Mrs. B. They're both the same age. They both got the same comorbidities. The only difference being is their frailty score. So one's got a frailty score of 3, Mrs. A, and Mrs. B's got a frailty score of 7. So in terms of, it's a bit morbid to think of, but in terms of longer term prognosis, we've got to start thinking in that way. What are we trying to achieve with these 2 patients? Because their frailty scores are quite different. And as you can imagine, because they've both got the same problems, they're both on the same list of medications. So I'm probably just going to chat you through this one, because we're going to have to look at both of them differently. So for Mrs. A, I'd probably just do a very similar review as to what we've just done for the previous patient. So thinking about the AEC score, what are we scoring? So this lady's on amitriptyline as well, scores really, really high. What's she taking it for? And I would say every time we do a medication review, we should, if we can, either involve the patient, because they might give you different information in terms of why they're taking something. And some patients in particular are quite passionate about staying on certain drugs because they do make such a difference to them, which probably we would think, you don't really need that amitriptyline, it's not good for you. And our viewpoint is completely different, so I would always involve the patient. Folic acid, so have we done recent folate levels? How long has she been on it? Is it still indicated? PPIs are a huge problem, so pretty much everybody I see in elderly care has a PPI. For if it's relevant or not, again, is questionable. A lot of the time it's things that have been added a while ago and now they're no longer indicated. So again, something to review. Ferrous sulfate 3 times a day. I highly doubt anybody takes iron 3 times a day. It's not a very nice drug, causes a lot of GI upset. And actually, have we looked at her haematinics? Does she still need it? Have we done iron levels? And actually, if she does, we can reduce that to once a day. Because there's a lot of evidence to say once daily iron is now more beneficial because you're more likely to take it as well. And the aspirin. So what is the aim of the aspirin? What's the indication? Is she more at risk of having a bleed? Because there's quite a high bleed risk associated with aspirin, probably more than we would imagine. So again, what are we using it for? If there's no indication for the use of that, we can get rid of it. And because Mrs A's frailty score is quite low, she's going to still have benefit from things like alendronic acid, her statin, given her comorbidities. So on the flip side, if we look at the other lady with a higher frailty score, so I would do exactly the same thing as what we've done for Mrs A, but there would be additional things to think about. Because she's more frail, because her prognosis probably isn't as good, she might not be independent enough to actually take these medicines, so chopping away at them gives her some sort of independence back potentially, because she'd be able to manage a smaller amount. Or in terms of her care calls, that would make her care call, if she is having care calls, a lot easier, because the carers are not spending all the time trying to administer a huge list of medicines. They're just giving her the ones that are really important for her at this time. So things like your statin, your alendronic acid, drugs that work over a longer period of time, she might have already had these for a good number of years and has got all the benefits she needs out of them. So they are something that needs to be reviewed. ADCAL as well, so ADCAL will go along with her alendronic acid. Again, longer term benefits, and does she still need it? Are we just going to improve her quality of life by chopping these medicines away? And blood pressure wise as well, so probably everybody in the room knows that as we get older, our blood pressure target is increased. So we're going to need less medicines to try and keep it within that target. It's less tightly controlled. So does this lady still need amlodipine and ramipril to control her blood pressure? Or by taking both, are we just giving her more side effects? Actually, she doesn't need both of them. So you can see the difference there between patients with different frailty scores and the different sort of approach to it. Again, something that takes a lot of time, but it does benefit those patients if we're going down the route of care and trying to help the patient holistically rather than sort of our individual pockets of treating certain conditions. So that's our case studies. I don't know if anybody's got any questions as part of them.
Yes, we're able to. I guess I asked about the apixaban. Yeah, so I just don't know what your view is regarding the apixaban as well. She's very frail, high risk of falls, and she's an inpatient. Every time she has a fall, she might bang her head. She'll always need a CT head because of the guidelines, and as the radiologist says, it's a tick box medicine. So what would be your views there about the apixaban as well, about the risk benefits?
Yeah, so that's quite a tricky one, and we do come across it quite a lot in secondary care. Patients on DOACs, and they are high risk of falls. It's quite a tricky conversation to have. So I would certainly include the patient in that, and if they can't sort of speak for themselves, their family members, because you've just got to highlight the risks and benefits basically, and let the patient family decide what's best for them. So yeah, you'd have to weigh up basically, if somebody was falling a lot, what is their likelihood of having a fall versus their risk of having a stroke, and using your things like CHADS-VASc and Orbit tool to try and help you with that decision as well. And that again is a visual to explain to family members, patients, of our school of thought and why we're doing what we're doing. So yeah, they're quite tricky conversations, but if you do have time to have them and you are particularly worried about somebody, especially in terms of falls, then they are definitely worth having. They just take a little bit of time, those ones. Yeah.
On now? Yeah. Going back to the apixaban, I mean, really we should have those conversations with anybody, regardless of frailty, and make sure we don't just reduce the dose because we think, oh, they might fall. But I just wonder if you'd have to fall hundreds of times, you know, a couple hundred times for it to move into that risk-benefit. And just thinking on that front, how they're falling is really important, isn't it? So are they suddenly going backwards because that's more significant than if every now and again they fall forwards and land on their wrists? So And it's an interesting case study.
Yeah.
And, well, we do it all the time, don't we? Which is a bit depressing, really.
Yeah.
Such a lot to do in 10, 15 minutes.
Yes. Yeah. Yeah, and I think the key thing is as well is in practice we wouldn't stop all of these things altogether. This would be a work in progress.
Yeah.
Because if we did stop them all together, it would be, you know, if something went wrong, we would know what we'd done basically. So yeah, just doing them sort of piecemeal really. I suppose in secondary care we sometimes have the luxury of that because we do have patients that are longer stay waiting for packages of care. So we do have those patients with us for a period of time, so we can chop away at these medicines slowly. But yeah, certainly wouldn't stop them all in one go is something to mention as well. As part of our work, we have had some patient feedback about polypharmacy as well. So I don't know if you want to chat about that.
Yeah, so we were really fortunate to attend the AWTTC Patient and Public Involvement Group, and we use it as an opportunity to try to get some feedback from patients to hear their perspective. So we had a discussion around polypharmacy and how they felt about their medications. And so some of the feedback we had is that it's really important that the healthcare professionals take the time to thoroughly meet the needs of the patient. It seems to be that frailer, older and vulnerable people do need someone in their corner, and that there are so many medications that each and every one of us take, and how is it that the medical professionals are assisting the patient? How are they engaging with the patients to actually hear what it is they have to say and how it can better meet their needs? So I wanted to include that just to highlight that it's not just obviously the risks that we've already spoken about that are really important, but it's actually the individuals who feel that they would benefit from these reviews, they would benefit from having that conversation with the healthcare professionals. You know, it must be difficult for them to take all these medications. So if you do come across someone on polypharmacy, please try and have that conversation with them if possible. And then lastly, then we want to just quickly go over some areas of polypharmacy. Not, you know, obviously there's so many areas in the health board that we try and look at polypharmacy, so we're just highlighting a few. So in Swansea Bay, one of the main things we're working on at the moment is the Welsh Government's 6 goals for urgent and emergency care. So the aim is to try and prevent care home patients being admitted to hospital. So it's a pilot for only 6 months, and we're trying to review 200 patients. We're working with Morriston Hospital. And basically, as a pharmacy team, we're reviewing medications, trying to prevent those falls, you know, any risks we can. And we're also trying to do some education for carers, so looking at, you know, high-risk medications, things like Parkinson's medications, dementia. And then also there's a rapid assessment. So if a patient has a fall or chest pain, they get seen by geriatricians in hospital. There's also the virtual ward. So we've got our virtual ward pharmacist, so I'm not going to say too much here, but they've got a table this afternoon, so that's a really great area for us to have the opportunity to review some of our frail patients. There's 8 clusters in Swansea Bay, and we've got a virtual ward per cluster, and again, like I said, there's a table this afternoon that the virtual ward pharmacist can discuss more about. Do you want to talk about secondary care a bit?
So the acute sites, we've obviously got a lot of elderly patients in the acute sites, regardless of what speciality they might be under. But we do have dedicated elder care wards and teams of geriatricians as well. So we try and get ourselves involved with those MDTs, do medication reviews, why patients are in. And yeah, looking at falls as well. So we're starting to do a little bit of work on falls. We've done audits in terms of how many people are falling. Do the pharmacy team necessarily know that the person's fallen? Because a lot of the time we don't get even told about it. To go and have a look at their medicines, to try and prioritise who we're looking at. We do have sort of ortho-geriatricians that do a lot of our sort of reviews in terms of orthopaedic wards. So we've been doing some work there. And then some future plans really. We've got a frailty assessment unit in A&E for older people. So we're hoping to start getting involved with them. And have a pharmacist actually in the unit and trying to help them do medicine reviews. And also we've now got a new acute medical unit in Morriston, and part of that unit has a frailty bay. So we've got a geriatrician, or 2 geriatricians on that frailty bay who do ward rounds every day, so we're hoping to get time to go on those ward rounds so we can actually do medication reviews when they're admitted, to look at why they've been admitted and then try and take away the potential drugs that are causing those admissions so they don't bounce back in, because sometimes we don't do that and they end up coming back in with exactly the same problem because nobody's really thought about their medicines. So that's what we're hoping to do, or are doing on our acute sites then. And then just to finish off, these are some of the references. Obviously the guideline we've been working on is slap bang in the middle, so please have a look at it, please use it. It's got a lot of information in it. It's a massive document, so I wouldn't expect you to read it all in one day, but if there's a particular area that you're stuck on, we've definitely got reducing regimes and deprescribing algorithms within it. So yeah, have a little look at it. We've got the stop-start tool that's in it as well, stop frail tools in it, and we've got lots of references at the back to other polypharmacy guidelines. So the Scottish one is really good. They've got an app as well, which we're hoping to do in the long run is to put ours on an app platform to make it more accessible. Yeah. Anything else?
No, I think that's it. Yeah, we'll stop talking about it.
Thank you so much. I think we've already got some hands up. So I don't know the table number, but in the far left hand corner there.
Hello. Oh, first time. Thank you. First of all, thank you for taking the time to update the document. I can't imagine that was an easy job, and it's very good, thank you. So I think my main question, I work in North Wales, head of pharmacy for primary care and community, and like you, we're kind of exploring a lot of these, putting pharmacists and techs into these areas where we're really getting a focus on deprescribing. But one thing we're really struggling with, particularly when it's done in an acute setting, is that communication, and I suppose both from a patient perspective, really involving them as a partner in the decision to ensure that they understand, and we're taking their wishes and baseline, particularly when it comes to frailty, into account. And then second of all, how that then is communicated primarily to their GP, but also from the point of view of community pharmacy and other services that I work with, so that it all doesn't get undone when they then go, oh, I don't know anything about this, I wasn't part of that conversation, and then it all goes back again. And that's not really anybody's fault, but I just wondered if you found any good strategies or got any tips for improving that communication.
I think it depends on the setting. We've had recent changes to our acute site, so we used to have a service with a integrated care of older people's assessment unit in Singleton Hospital, where that was a really good opportunity because we'd have an MDT that's specific in frailty, and we'd have technicians that would do compliance reviews, so we'd be able to take that time to really sit down and talk to the patient and review their medication, and then that could be fed on. So we've got medicine management team in primary care where they will review medications to look at compliance and go into the patient's home. So we had that good communication, that good link. Recently we've had changes to the service. They've moved to Morriston and things have changed. So we're trying to re-establish a similar service there. But I guess it's always just trying to make sure that you, like you say, include the patient, take that time. But it is obviously really difficult in acute sites when you're really busy. We do have, we try and write notes, don't we, at the end of the discharges, but I definitely think that there's more that we could do in that area, but it is time limited, isn't it? So it's all dependent on how much time and resource you have.
Yeah, I think you've got to be proactive as well. So like sometimes I come across patients that were in the middle of weaning things and we wanted it to be carried on. So you know, I've taken the opportunity just to email primary care and say, I don't know who's covering this GP surgery, but can we pass on this information to the pharmacy team in that area? So yeah, I think it's just about being a little bit proactive as well, and writing things on the discharge information. So I write quite a lot of notes of why we've stopped certain things in the information to the GP, just to make it a bit clearer of why we've done what we've done and whether something needs to be carried on in primary care then.
And do you have virtual wards in your area? I don't know if that's something you have. No. So we're really fortunate. We've got virtual wards as well. So we've got some, great relationship with the pharmacists who we're able to hand anything over if we need to, and they tend to look at some of our frailer patients as well. So I guess it depends on the services you've got available as well, isn't it? Not a great answer there for the services. Sorry. But
No, it's fine. I just think probably what you said about the writing what you've done, if I can implore everybody to do that who does this type of polypharmacy work, because when it's then received at the other end, you have absolutely no idea if it's an omission or a planned piece of care, and that then causes so many problems within the system. So it's good to hear that that you're considering kind of making sure that it's communicated, because also it would have been a complete waste of your time then if it gets restarted, never mind the fact that potentially the harm that it would cause to the patient. So I'm reassured to hear you don't have the magic answer, but it is something that we really need to be focusing on, is how then these decisions are communicated effectively, so they last.
Just touching on that as well, there's the discharge medicine review service, isn't there, with community pharmacy. I know in our health board we've got an option where we can, specify a certain pharmacy, and they've recently done some work to try and promote the service. So perhaps it's having those conversations with the community pharmacists as well, because they're going to be reviewing their medication, so that might be another option. I don't know.
Yeah, and we've got electronic prescribing in Swansea Bay, and I know some of the primary care pharmacists have read-only access, so you can go back into the patients who have been admitted, look at their history, and we do a lot of care plans basically on that system of what's happened pharmaceutically while they're in. So like I would document a lot of things as to what's been stopped, why they've been stopped on that as well. So I know if somebody's doing a medication review in primary care and they've got read-only access to that system, they can go back and have a look at what's happened to the patient while they've been in hospital. So that's quite useful. A positive of e-prescribing. Yeah.
We've got time for one more question, I think, and then we'll got a few housekeeping for lunch.
Oh, everyone's keen for lunch, that's fine.
Well, no, it's excellent. So thank you so much.
You.
And I think your case, you had to shut us up. We were discussing it so much. So so it was really good, and I think there's probably quite a few conversations you're probably going to have over lunch.
Great.
So thank you so much.
Thanks.